This is the Learning Plan 8 High Risk Perinatal, and this class recording is going to include the issues about drug dependency in pregnancy, diabetes in pregnancy, and trauma during pregnancy. So we start with drug dependency, and this becomes a high-risk situation in pregnancy because it increases the risk for both medical complications in the mom and poor birth outcomes in the baby. In the childbearing age group, it is becoming a big health problem. 10 to 20% of pregnant women use illegal drugs during pregnancy, and cocaine is a popular one with multiple drugs in addition. However, probably the one that's becoming the most prevalent is heroin use. We have a big issue with heroin anyway in our communities, and that doesn't leave out the pregnant population. There is a methadone clinic in Marathon County, and the greatest percentage of people who use the clinic are pregnant women. And that is a huge reason, even without that being a reason, that we need to assess all pregnant women for the possibility. Again, this is not one of these situations where you can eyeball somebody and say, oh, you probably have a drug dependency, and oh, you I know don't, because it crosses all levels of people. Some of your possible signs that would raise a red flag would be someone who's seeking late or no prenatal care, and people who are having difficulty following their prenatal instructions. Those are just some possible signs, but again, we need to really assess all pregnant women. Some of the issues with illegal drugs is that the fetus is going to experience the same systemic effects as the mom, but often more severely because they are so tiny. These drugs are usually small molecular weights, therefore they cross the placenta very readily, and the fetus cannot metabolize the drugs efficiently and will experience the effects long after the mom stops. The fetus and mom stops having the effects of the drug is what I mean. The fetus of addicted moms has a drug concentration of 50% of the moms, and that accounts for 4 to 5% of fetal abnormalities. The drug could have a direct teratogenic effect, or it puts mom at risk for other issues like HIV, hepatitis B, and other sexually transmitted diseases because they're not thinking clearly while they are using the drugs and make some poor choices. So some of the drugs that are commonly used, we'll start with cocaine. It has become one of the most frequently abused drugs, but as I mentioned, heroin has recently taken over with that. Cocaine increases the respiratory rate, the heart rate, and the blood pressure, and it stimulates uterine contractions, so premature delivery is very common. It's very harmful in pregnancy because it causes extreme vasoconstriction, and that severely compromises the placental circulation. So what you see are fetal congenital anomalies, maybe abruptio placenta, spontaneous abortion in some cases. IUGR is intrauterine growth retardation in the fetus, and sometimes stillbirth. Now, infants might have, if they survive, they might have intracranial hemorrhage due to the increased blood pressure, low birth weight, withdrawal symptoms, and this is just a small list of tremors, tachycardia, irritability, muscle rigidity, hypertension, and they have an exaggerated startle reflex, and they can have long-term learning deficits. We will go into a lot more detail about the neonatal abstinence that infants go through when we talk about the high-risk newborn. Amphetamines, their use was increasing for a while because they're cheap, but actually that's why heroin use is increasing, because it's cheaper now. The newborn will have some jitteriness and be a poor feeder. Marijuana, it crosses the placenta and it accumulates in the fetus. You see tachycardia in both mom and baby. And with repeated use, you'll see increased incidence of maternal anemia and an inadequate maternal weight gain. For some moms, that's why they take it, so that they don't gain too much weight. Newborn, again, the IUGR, decreased intelligence, unusual sensitivity to light, tremors, and hyperirritability. And you'll see a decreased milk supply for the infant if mom used it during pregnancy and or lactation. PCP is an animal tranquilizer. For a while, this was becoming very popular to use. It increases the cardiac output, and it tends to leave the maternal circulation and concentrate more in fetal cells. Opiates like morphine, Demerol, codeine, heroin. As I mentioned, heroin use is huge now among pregnant women and other people. Pregnancy complications, you'll see PIH, pregnancy-induced hypertension, phlebitis, elevated blood pressure for mom, bacterial endocarditis, and an increase in HIV and hepatitis B. Fetal effects, fetal opiate dependency, small for gestational age babies, that's the SGA, increased fetal distress during pregnancy, and the risk for meconium aspiration. So heroin, as I said, the use is increasing and it's still ever increasing. It's a CNS depressant. It produces severe physical addiction. It's also an appetite suppressant. It interferes with the absorption of nutrients. So many women start pregnancy already malnourished and anemic if they've been on heroin. Women who abuse heroin have poor general health with multiple medical problems associated with the drug abuse and that whole addicted lifestyle, where you have that high incidence of STDs, STIs, hepatitis, and HIV exposure are common as a result of sharing needles. And typically, women who are addicted to heroin come to the labor and delivery intoxicated from a recent drug administration because it often stimulates labor. When that drug wears off, you'll see the withdrawal symptoms: yawning, diaphoresis, rhinorrhea, restlessness, and the excessive tearing of the eyes. So the effects on the fetus. The issue about heroin is that the street supply is usually not steady. The fetus suffers those episodes of maternal overdose, alternating with periods of withdrawal. And some women are trying to not take it, and that's why they also have those periods of withdrawal. This exposes the fetus to periods of hypoxia, which increases the risk of prematurity, growth restriction, and stillbirth. And then there's those indirect effects that are caused by the maternal malnutrition and the fetal exposure to some sexually transmitted infections. Alcohol. Alcohol is considered a drug, and it crosses the placenta in the same concentration that is present in the maternal bloodstream. And let me go back just to say about heroin that with methadone, moms have less issues than they do with heroin. However, methadone is still an opiate alternative, and you can still see withdrawal in both mom and baby, but it's a better alternative. Okay, so back to alcohol. Alcohol is going to cross the placenta in the same concentration that mom has in her bloodstream. And so that we don't know if there's any safe threshold of alcohol ingestion during pregnancy. Therefore, all pregnant women are advised to avoid alcohol intake of any kind to avoid any teratogenic effects to the newborn. Women who have alcohol addiction should be referred to alcohol treatment as soon as possible to help reduce their intake. And what we worry about with the fetus is FAS, fetal alcohol syndrome. The incidence is about 2 in 1,000 newborns. They'll have growth restrictions, CNS impairment, so learning difficulties, etc., and facial features. They have the flattened brim of the nose, the wide-set eyes, kind of flattened facial features. And if you see several children in the family, each successive child, each successive pregnancy, those facial features are more exaggerated. And also their growth restriction and their CNS impairment more exaggerated with each successive child. Tobacco, considered a drug. And so we think about cigarette smoking, and that has been shown to have teratogenic effects on the fetus, especially growth retardation. So these kids will be low birth weight. That results from the vasoconstriction of the uterine vessels, which limits the blood supply to the fetus, as well as the fact that they get inhalation of carbon monoxide. And this happens also with secondhand smoke while mom is pregnant, but also while the baby is alive as a newborn. Now, prematurity has other neonatal consequences, which we'll talk about with our high-risk newborn. Smoking is also associated with delayed neurologic and intellectual development. So you'll see these kids have hyperactivity, a short attention span, lower reading and spelling scores later. And SIDS is twice as frequent, sudden infant death syndrome, twice as frequent in children of smokers. And these children will continue to be underweight during their early years, so up to the age of 3 for sure. So smoking cessation is a huge issue to talk about with our patients. It's very, very difficult for the average woman to stop smoking. So even if we can get them to reduce the number of cigarettes smoked per day, would help to diminish some of those adverse fetal effects. And we don't want them using drug therapy such as a nicotine patch or Chantix or something like that, because it may be as harmful to the fetus as the actual smoking. It's amazing, though, that this is one window of opportunity where maybe you can get the mom to quit for the effect of the baby. However, it's amazing how they can stop for 9 months, and as soon as they deliver, they go back to smoking. But at least they've protected that fetus while they were pregnant. So what are some of the nursing interventions that we can do with people who have substance abuse or substance use, like with the smoking and the alcohol? Effective interventions really require the nurse to have a good relationship with that patient. And we have to realize that progress is always very slow and frustrating. Women are not likely going to tell you the truth the first time you ask them. And so it's that rapport you develop. And even then, they will have peaks and valleys of success and, falling back on prior use. The major priority for the nurse is to protect the fetus and the mom from those harmful effects of the drugs. So as nurses, we need to examine our own knowledge and attitudes about it. We need to get more educated, communicate with the woman, and show genuine interest and concern. Ask her about stressors that may contribute to her substance use, and be honest at all times, and be patient, and be non-judgmental, and that is very, very hard sometimes. Help the woman to identify her strengths, empower her, because when she feels empowered, she's going to be much more successful, and provide ongoing care. The current status of substance abuse should be evaluated at each visit. Verify the compliance with her recommended treatment, what kind of social service needs, other referrals are needed, what kind of education does she need. And as a nurse, we need to coordinate the care among the various providers, and then be aware of assessing that maternal-infant attachment behavior, or at this point, the maternal attachment to the fetus. So now we move into diabetes and pregnancy. Pregnancy is complicated when a woman has diabetes, and it's always considered a high-risk situation. And to manage diabetes successfully, we need a multidisciplinary approach. There's the OBGYN physician, along with the internist, along with the neonatologist for the baby, the nurse, the dietitian, the social worker, etc. Anybody else who's needed, but for sure those. Every woman who has successful regulation of their glucose and insulin metabolism before pregnancy is apt to develop less than optimum control during pregnancy. And this is every woman, not just those who have diabetes, because of those major changes that are occurring in the insulin regulatory process during pregnancy. So the pathophysiology here is that you have glomerular filtration of glucose that is increased during pregnancy. The rate of insulin secretion is increased, and therefore the fasting blood sugar is lowered. And so all women seem to develop this insulin resistance during normal pregnancy to prevent blood glucose from falling to dangerous limits, despite the increased insulin secretion. Insulin does not seem to be as effective during pregnancy. And so if you have a healthy pancreas, that can probably handle that. But for some women, their body just cannot keep up with that glucose load, and it's made harder during the pregnancy situation because of this pathophysiology. So now if you have a diabetic patient, she then must increase her insulin dose to prevent that hyperglycemia. And that usually occurs around 24 weeks. But at the same time, we need to watch the continued use of glucose by the fetus, because this will lead to hypoglycemia in the mom, especially between meals and at night. So you can see why it's a complicated situation that you need everybody involved. The maternal glucose is transported to the fetus through the placenta, but the maternal insulin does not cross the placenta. Now, by the 10th week, the fetus can secrete its own insulin. So the primary problem here is that you have control of the balance between the insulin and the blood glucose to prevent acidosis. So that's a threat to the fetus. A constant supply of glucose is necessary, though, for growth and development of the fetus. So we have different types of diabetes in pregnancy. We have those women who come into pregnancy already diabetic. The pre-existing diabetes mellitus. It existed before conception, and it's going to continue after the pregnancy. And then we have the gestational diabetes that occurs just with pregnancy because of all those major changes. You have the carbohydrate intolerance of variable severity with the onset or first recognized during pregnancy. Now, these women generally are not diabetic after the pregnancy. However, that does increase their risk for developing diabetes mellitus later in life. So the incidence in pregnancy of diabetes mellitus is 0.1 to 0.5%. And the research has demonstrated repeatedly that the best predictor of pregnancy outcome for the diabetic and her baby is the degree of maternal glycemic control during pregnancy. So it's not okay for her blood sugar levels to go way high, and then she takes insulin and it comes crashing down. We want to try to keep her at a controlled glycemic level. The first trimester is the most critical time for fetal development. So if the mom's glucose level can be kept from becoming hyperglycemic at that time, the chances of any congenital anomaly are greatly lessened. Now, the maternal risks and complications, there's a higher risk of spontaneous abortion. There's a much higher risk of preeclampsia, 25 to 30%. Also have a higher risk for hydramnios, and that is the polyhydramnios, the amniotic fluid that is greater than it should be, so greater than 2,000 milliliters. And that occurs in at least 25% of the diabetics, and it's probably because of the hyperglycemia in the fetus, and that's causing the fetus to have increased urine production. Remember that the fetus is going to urinate into the amniotic fluid and going to swallow amniotic fluid. So if there's something going on with the fetal kidneys, in this case, a lot of urine output, you're going to have polyhydramnios. Also just called hydramnios. Oligohydramnios is not enough amniotic fluid. They're at a greater risk for preterm labor, infections. There's a much higher risk for a C-section because these babies are so much larger. And then there's the risk for postpartum hemorrhage because of the large baby. That uterus has stretched to a greater level. Now, fetal and neonatal risks and complications, we'll go into a lot more of this in the high-risk newborn, but just know that they are 2 to 8 times more likely to have congenital anomalies, usually in the CNS system, the cardiovascular system, the urinary system, and the GI system. And as I mentioned, they are big babies. The special name for that is called macrosomia. where you see an infant weight greater than the 90th percentile, because the fetus is responding to the maternal hyperglycemia by excreting large amounts of its own insulin. And insulin acts as a growth hormone, so that causes the fetus to lay down excess stores of glycogen, protein, and adipose tissue. Now, dystocia is the term for a difficult delivery, and therefore with these large babies, sometimes they can have some difficult delivery and may suffer from some birth injuries like a fractured clavicle, a lacerated liver or spleen. Newborns always have a larger liver and spleen, so there's more risk for that. Brachial plexus injury, facial palsy, a phrenic nerve injury, so any of those nerve injuries, and then subdural hemorrhage or asphyxia. Excuse me. Hypoglycemia can occur because the baby is used to mom's, excuse me, the baby is used to mom's high levels of glucose, and so it has stopped producing a lot of, it is making a lot more insulin, as we mentioned, and so they are often then born hypoglycemic because they don't have the advantage of mom's high levels of glucose anymore, and their body has been putting out so much insulin. So within the first 30 to 60 minutes after birth, we assess them for hypoglycemia, and many times the first 24 to 48 hours, they need some medical management to control their hypoglycemia. Now, gestational diabetes, the women who get diabetes when they become pregnant, is characterized by a mild glucose intolerance. So you see this hyperglycemia. 2 to 6% of all pregnant women develop this, although that is increasing. A lot of that has to do with our higher levels of obesity. It's most often encountered in late pregnancy, so about 97% of the time. It's a high probability it will occur in subsequent pregnancies, and there are those long-term implications that I mentioned. They have a risk for developing diabetes mellitus within 20 years, so 50% of them do, especially if they're overweight. And usually gestational diabetes can be managed with nutrition and perhaps exercise alone, and those women may not need to take insulin at all. The people who have a risk for gestational diabetes are any mom over the age of 30, any mom who's obese, has a family history of type 2 diabetes, has had a birth of a 9-pound or larger baby, and any mom who's had unexplained stillborns, miscarriages, or infants with congenital anomalies. So the maternal and fetal risks are going to be the same for the woman who has gestational diabetes as the mom who comes in with pre-existing diabetes mellitus. The assessment for diabetics then is that we need to screen all women, because we know that universal screening is so important because every woman has greater issues during pregnancy. So 70% of the women who develop gestational diabetes are asymptomatic at first. So another reason for that. They can do the hemoglobin A1C test. They can check for glucose in urine, or they could do the glucose screening test where they have them drink the high sugar solution. They will have them do home glucose monitoring if they're worried, can check ophthalmic exams because it can affect the eyes, and look for urine problems, look for UTIs because they're risk of having problems with recurrent infections. So some possible nursing diagnoses we would see, and then we focus our interventions around these. Risk for altered tissue perfusion related to that reduced vascular flow. Altered nutrition less than body requirements related to the inability to use the glucose. Risk for ineffective individual coping related to the required change in lifestyle. We're saying risk for, right? Risk for infection related to the impaired healing accompanying the condition. fluid volume deficit related to polyuria accompanying the disorder, and knowledge deficit related to the difficult and complex health problem. So those are the areas that we're going to really focus our nursing interventions. So nursing care and management. Preconception care is very, very important, especially when women are diabetic, to try to get them as much education and knowledge and get them as healthy as possible and get their glucose under control, ideally before they ever become pregnant. Educate them about that good glucose control, educate them regarding their diet. And diet is very individualized, but in addition to watching carbohydrates, a very, very good diet for all diabetics is a high fiber diet, because high fiber slows down the absorption of glucose and it allows their glucose levels to stay at a more steady level. And remember, that steady level is so important for all diabetics. Educate them regarding exercise, and they need to know how to do blood glucose monitoring. And we never treat them with oral hypoglycemic medications because they cross the placenta. So instead, they will be treated with insulin if they need that, and monitor fetal well-being throughout. So insulin management, when we look at that, in the first trimester, the insulin needs generally decline because of the secretion of placental hormones, and that initiates the maternal resistance to the effects of insulin. But those secretion of placental hormones remain very low in the first trimester. In the second and third trimesters, the insulin needs increase dramatically when those placental hormones reach their peak, and during labor, we have to maintain a tight maternal glucose control so that we can reduce the neonatal hypoglycemia, and they might even need insulin IV. Now, postpartum, the mom's insulin needs will decline rapidly after delivery, but remember, this is where we now have problems with the baby. So timing of delivery is important. Pregnancy should always be allowed to progress to 39 weeks if possible to allow the fetal lungs to mature. However, the placenta of diabetic moms matures faster. When we say matures, when the placenta is mature, it gets to its maximum size and functioning, and it starts to shrink and atrophy and lose full functioning. So timing of delivery is important because we really don't like them to go to beyond 39 weeks for that reason, because we've lost the effectiveness of the placenta to that fetus. And throughout, we are monitoring fetal well-being to determine that timing of delivery. We have some case studies, with the one case study that we'll look at when we discuss diabetes in class. Now, trauma and pregnancy is the last bit of this class recording. So the incidence of trauma in pregnancy is about 6 to 7%. It can be as many as 250,000 cases per year due to auto accidents, homicide, and suicide. Those three things are the leading causes of death in the childbearing age group. There's a high incidence occurring in the last trimester of just accidents due to clumsiness, fainting, and hyperventilation. So women they lose their balance because of that large pregnancy. They maybe are not wearing sensible shoes, etc. So there can be those orthopedic injuries from falls. Broken wrists and sprained ankles are very, very common because of that change in the sense of balance. And also, if there is an auto accident, the pregnant woman is often the front passenger, and this is the person generally in any car accident who receives the most severe injury, just by the statistics. Different types of pregnancy trauma. There can be open wounds like lacerations, puncture wounds, animal bites, also blunt abdominal trauma from a motor vehicle accident or a battering situation. Gunshot wounds, and those are always reportable to the police. Poisoning, choking, orthopedic injuries, burns, and battering. Now, nursing diagnoses that we have to think about is fear related to the threat of injury to the fetus, risk for fetal injury related to trauma, and the risk for altered tissue perfusion related to blood loss from the trauma. Remember the size of those placental blood vessels, some of them as wide as a pencil thickness. So there is always a huge issue of bleeding out and having huge blood loss. But then we also have the idea that the body tries to protect that by increasing the fibrinogen levels of a pregnant woman, which is what makes her at greater risk for DVT after pregnancy. But we do have a little bit of protection there, but still a major trauma is going to be a huge blood loss. The physiologic changes that occur in pregnancy after any traumatic injury, a woman's body will try to maintain her own homeostasis at the expense of the fetus. And know that a woman's total plasma volume increases during pregnancy from 2,600 milliliters to about 4,000. And this serves as a safeguard if bleeding occurs, but also they can lose more blood than normally before hypovolemia occurs. This also means she needs more fluid replacement to restore her circulatory volume. And approximately 1/6 of her total blood volume is present in the placenta at all times. So any kind of uterine laceration is always serious because she can be losing up to 1/6 of her blood volume very quickly. The peripheral blood flow is also increased in pregnancy, so pregnant women can be in severe shock, and you won't see those cool and clammy extremities, so you can't look for that usual sign. And abdominal pain is very difficult to localize because all of her organs are pushed aside by the growing fetus. So just so she has right upper quadrant pain doesn't necessarily mean that's where the liver is or whatever, because that can be pushed aside. Now, during pregnancy, her WBCs are also normally elevated, so it's very difficult to determine if she has an infection, if she has an open wound. And the other thing is that her bladder, keep in mind, is very susceptible to rupture because it is most anterior. And it's also elevated abnormally because of that fetus that is pushing everything aside. So nursing care and management, we have to assess her very quickly, yet be thorough. So we have to look at the psychologic as well as her physical status. So we have to do a very quick assessment on both mom and baby, assess the fetal status, try to locate her support people, try to figure out whether her pregnancy has been healthy and normal, what about her health. Do a quick physical exam. You're going to evaluate the lungs, the heart, the brain, and the placental function first and try to immediately stabilize her. And keep in mind that if a pregnant woman does not survive, they may need to do a post-mortem C-section to save the fetus. Now, they will attempt that if the fetus is greater than 24 weeks, because before then, there's just no chance that that fetus can survive. And if it's been fewer than 20 minutes since the mother's death. That sounds like a horrible situation to have to make a decision about. Now, what I do want to say about this issue of battering in pregnancy is we never want to think about that could occur. However, the statistics show that many times a trauma situation, a family interpersonal violence situation, either becomes escalated or first starts when a woman is pregnant. If you think about the dynamics that go with interpersonal violence, we know that it is an issue of power and control. So all the things that are happening during a pregnancy where the mom is so focused on what's happening within her body and that fetus, rightly so, can place that perpetrator, which is usually the male, not always, but in this case would be, puts them in a more vulnerable situation because they feel as though they're losing their power and control. Not that this is any kind of excuse whatsoever. It's just an explanation as to why it can occur more in pregnancy. And so we always have to be aware of asking about this and assessing for this. However, again, what is the chance that they will be totally honest with you? It's sometimes asked many times of asking, before they will admit to anything, or many times of them being injured and being asked before they will admit to anything. So this is going to end the class recording on this section of high-risk perinatal, and the last recording is going to focus on the intrapartum complications, and that will be next.